So as Glenn mentioned, I work in Marin County. I used to work at UCSF with Dr. DePinto. In fact, both Dr. DePinto and I were here at the University of Washington when I was a resident. He was an attending. I dragged him down, I want to say, down to the Bay Area. And then I left academics about 2 years ago and now work with a group of orthopedic surgeons. My disclosures, I am totally conflicted, as we like to say. So one of the things I really enjoy is this innovation in this field. And one of the things I learned with Dr. DePinto and during fellowship is that I certainly hope we're not giving opioids and injecting steroids for the next several decades. So a lot of the things that I've been working on, you'll probably recognize some of these companies, but many of these companies probably never even heard of, and you might not even be able to do a Google search on them, but you may hear about them in a few years, or they may fail. We'll see. So quick table of contents here. We're going to go through the background of neurostimulation, the diagnoses, briefly touch on some principles and the evidence, go through who the vendors are today, and then give you some taste of the societies and journals you should be involved in and how to make good decisions in this field. So spinal neurostimulation, what you should always be asking yourself is, how do I explain this to my grandmother? Because if you can't explain it to your grandmother, how are you going to explain it to your patients? So one of the things I kind of memorized when I was a fellow, several years ago was, neurostimulation is providing an electrical current to an electrode that resonates at a specific frequency in the spinal columns to mask pain. And back when I was a fellow, guys, we had to create a paresthesia. There was tingling, you'd feel a vibration, and that would sort of, mask the pain. These days with the newer waveforms, right, you don't feel that. So there is more to it than masking pain, but nonetheless, this is the definition I used. So you all probably remember this table and probably have it memorized from med school all the way through today. What are the nerve fibers we're most interested in pain management? C fibers and? I think I'm hearing A delta. Yeah, it's written up there. And so this is super important, right? I mean, our ultimate goal, whether you do regional anesthesia or interventional pain, is to affect these nerve fibers without affecting the others, right? I mean, if you completely blocked a nerve, well, that's going to lead to paralysis. So what we're trying to do is differential blockade, really inhibit the C fibers and A delta fibers. And a lot of what electroneurostimulation is about is doing that. And there are different ways to go about it. The entire field probably spun off from this theory, the gate control theory that you're all familiar with from 1965. The application of the theory was almost immediate. Just 2 months later, a neurosurgeon, Dr. Sweet and Patrick Wall, they provided peripheral nerve stimulation to the ulnar nerve and did experiments in the OR to see what was happening with conduction. And they noticed that there was some success, and then as you all probably know, 2 years afterwards, Norm Shealy out of La Crosse, Wisconsin, placed a unipolar SCS right on the spinal cord itself. So this was that paper published in Anesthesia and Analgesia in 1967. There's a picture of the actual electrode sutured on to the spinal cord itself. This was kind of a revolution for the time, even though this patient didn't fare well because she ended up passing away 3 or 4 days later. It was sort of a terminal cancer care case in which they gave it a try. And obviously before she succumbed to her condition, they had all noticed that she did have some relief in her pain. So that was the beginning of the human experience with dorsal column stimulation. And then since then, there's of course been over 50 years in evolution in this technology where we started to use it in the epidural space, and that was actually done first in Japan. Then we improved from a single electrode or double electrode to 4 electrode. And it wasn't until the 1980s you actually had an implantable pulse generator. So prior to that, everything was an external power source, which is kind of ironic because guess what the new thing is today? There's some external power source companies coming out. Then we expanded our electrodes to 8. Then we moved on from 1 lead to multiple leads, rechargeable IPGs in the 1990s, being able to use it in an MRI 2007. Again, more electrode arrays, specifically with Boston Scientific and their Infineon lead. Positional sense was used by Medtronic. And then in 2015, things really changed. And this was just a few years after I was out of fellowship. This was our first major RCT in neurostimulation with the Senza RCT and Nevro HF10. That was really the beginning of seeing what this technology could really do for the mass market. It wasn't just our small group of people talking about how great this was. That paper was published in Anesthesiology and, of course, got a lot of press and created an entire company. Soon afterwards, the FDA approved DRG Simulation, which we'll talk about at the end. Currently, there's now a new implantable microstimulator on the market, and then in the future, you're probably already hearing about it, but Saluda Medical is coming out with feedback systems and spinal cord stimulation. So the hardware, there's so many variables to think about, but really I'd like you to divide it into hardware and software, okay? So the hardware, the leads, percutaneous, paddle, and then the implantable pulse generators, and then I want you to think about the software. So that is, what kind of current, resistance, voltage, patterns, amplitudes, frequencies, pulse widths, et cetera. So just really start to think about that and divide those two out. I strongly encourage you, especially during this year, to sit with the reps and program with them. Don't just have them go in a corner and take the patient away and let them do it. You guys have to understand what's going on, because a couple reasons. Number one, that you should know what's going on. The patient's going to expect you to know what's going on. And secondly, our reimbursement is probably going to change in the future, so that it is really incumbent upon you to actually do the programming and not industry. All right, so just diving a little bit deeper into the spinal elements, I think one super important takeaway that was described from this paper from Oakley and Prager in 2002 was that the biggest resistance to the electrical field is the CSF, okay? So because we're putting those leads or the paddle in the epidural space, it has to traverse across that river of CSF, then get to the dorsal columns, okay? So as that CSF changes based on heartbeat, respiratory rate, position, whatever else, that's going to change your stimulation, okay? So you need to remember that. And it's one of the interesting ideas about maybe using a larger paddle lead or even DRG stimulation, in which there's so little CSF that there's very little variation with all those issues. So waveforms, you're gonna hear a ton about it, whether you go to, well, you can't go to ASRA because it's happening right now, but if you go to NANS in January, which I hope you all will, you're gonna hear a ton about waveforms. So historically, again, pre-2015, we were all using tonic stimulation, and our parameters are pretty simple. Change the amplitude, change the frequency maybe subtly, not very much. Usually it was around 40 to 50 hertz, and the pulse width. Then with HF10, which is in the bottom left, it's a square wave. It is proprietary. It's not just cranking up tonic to 10,000 kilohertz. It really is a different proprietary waveform, and it was paresthesia independent, meaning the patient didn't feel it, which is very novel for the time. Of course, the caveat to that is when you use such a high frequency, it's a huge energy demand. So in order for that to work, the IPG had to be a little bit larger and had to be recharged basically every day. So that's the drawback when you go to higher frequency waveforms. Now, during the late 2000 knots, shall we say, and into 2010 and 12, Dirk de Ritter, a neurosurgeon who's out of Belgium, Netherlands, who now lives in New Zealand, came up with a burst waveform. And the way he came up with that was by understanding the way neurons in the thalamus were firing. They have both regular tonic firing, which you see in the upper left, and then there were some neurons in the thalamus that fired with this burst pattern. So his postulation was, what if we fired back at the neurons using this burst waveform? So we basically created a synthetic electrical stimulation mimicking that burst waveform. And the most important aspect about this burst waveform is that it's charge balanced, right? So it's not just doing a micro envelope of high frequency followed by a quiescent period followed by that high frequency envelope. It's actually charge balanced, and that's why you see that stagger and then that refractory period as it comes up. Super important because dosing of the electrical energy to the spinal cord or dorsal column is far less than what you would see with HF10 or other waveforms that are out there. And what's also interesting is there's some research being done right now on the psychological aspects of that waveform. All right, so cruising through, I want to describe what are known as the SAFE principles. Does anyone know what the SAFE principles are? Every UCSF person should be raising their hand. So they're just shy or haven't had enough coffee. So S is safety, A is appropriateness, F is fiscal neutrality, and E is efficacy. And these principles were actually described by Dr. Lawrence Perret and Elliot Crames in how do we as physicians adopt a new therapy? How do we understand if the next widget coming from spinal cord stimulation is going to be appropriate for our patients? And these are sort of the checklists to go through. You might take for granted how safe some of these technologies are. Myself, these guys here can tell you there were lots of issues with technology, batteries heating up, fractures in paddles or leads. We've gotten better and better and better over years, but any new technology is going to have those hiccups. So it's really important to understand, of course, the safety and, of course, your procedural technique in that, how appropriate it is for that patient. How much does it cost, right? Because these batteries will cost anywhere from $20,000 to $50,000. Is that appropriate for our healthcare system when we're spending one out of every $6 of our GDP towards healthcare? And then how efficacious is it and sustainable? So going back to a Kumar article that's now 12 years old, Kumar was a neurosurgeon out of Canada. He did basically almost all the neuromodulation in Canada at the time. He unfortunately passed away just a few years ago. But what he did is he tracked his outcomes, which is super important for you to do. You can't just say, I'm great, I'm the best, or I give lots of talks, I'm awesome. You really need to track your outcomes, and Dr. Stauner is going to talk about that in just a bit. But what he found was his lead migration rate, 13%, lead breakage, 9%, device malfunction, 2.9%. And those are hardware issues in the blue. The pink are sort of the, shall we say, clinical issues that will come up. And infection, is something that's, I'll say, somewhat unavoidable, but we can definitely get it down to less than 1%. That's why my rate is right now. Neuraxial hematoma, again, there are going to be chance encounters of this, although it shouldn't be that high of a rate, and we'll talk about ways to reduce that. CSF leak, we can talk about that. And then the bottom issues are really kind of whether procedural, technical, or the patient experience. So some of that may have to do with technique at the bottom or patient expectations, and of course a lot of that is mitigated by the newer waveforms. So if you look at all those numbers, and I'll just go back, if you add those all up, 1 out of 3 patients is going to have a complication. It's not good. Not good. You don't want to tell somebody 1 out of 3, 1 out of 3 of you is going to have an issue, right? So, a lot of what's changed in the last few years, and by the way, our percentages for all these issues has gone down significantly. There's a Holzer article out of the Mayo. Just in 2017, the rate got down to 2.4%. My rate currently, ever since leaving UCSF, is 0, actually. But when I include my UCSF cases, it's less than 1% right now. Lead migration was an issue for me early on. That was just me, the anchoring technique, whatever else, but I refined that technique. So do keep an eye on what sort of things are an issue for you and how to improve on that in your futures. All right, so the covered diagnoses, I like to, again, simplify this into 2 buckets. There is the neuropathic pain situation or indication, and then there's the ischemic. And in the United States, you guys are probably less likely to see the ischemic issues, although hopefully as we try to gain more indications through the FDA labeling, you'll see that. But in Europe, they will use spinal cord stimulation, for example, for peripheral vascular disease or for angina. It's actually part of their cardiological society guidelines. So diving deeper into neuropathic pain conditions, these are some of the most common in FBSS, or quote-unquote failed back surgical syndrome. I hate that term, but anyway, it's what's used. It is the #1 diagnosis that's being used for the CPT code 63650 for spinal cord stimulation. #2 is complex regional pain syndrome, and then some of the other diagnoses you will see are radiculopathy, whether cervical or lumbar. So occipital could be done with spinal cord or peripheral nerve stimulation, phantom limb, post-amputees, diabetic peripheral neuropathy, PHN, and then peripheral neuropathies. And then as I mentioned, the ischemic issues are really specific to Europe. Just because of labeling and indications doesn't mean you can't do it. It's just that the payer may not pay for it. With that said, I have had a few patients with cardiac syndrome X or angina receive a spinal cord stimulation from me. And that was just a fight with the payer to approve it, giving them all the data. And again, we can talk about that through this weekend. How do you get something done when you think it's right and the payer doesn't think it's right? All right, so I'm cruising along. I know this is fast and whirlwind, but I just want to get all these points across. Getting to the F in SAFE, the fiscal neutrality. How cost effective is spinal cord stimulation? So we've done a few papers looking at the cost of spinal cord stimulation versus if a patient goes through conservative care for their condition. And you will see that this graph basically tells it all, in that if you take a patient who has a spinal cord stimulator and you look at their upfront costs, of course, it's much higher, but the subsequent costs won't increase as greatly as if they had conventional medical management. And so that crossover point is really about the 2 to 3 year mark, depending on which study you look at. This is the D article from Neuromodulation. So one of the things I tell patients is I'm not happy unless this therapy works for you for at least 3 years. Okay? So if you make someone happy for 6 months, you haven't done your job based on this. If you really care about the fiscal aspect of the technology you use, because if we all just used $50,000 implants that work for 6 months, we would drain our healthcare system, and guess what? They'd probably take it away from you from doing it again. So we need to prove that there's longevity with the therapy. And so some of the papers you should have in your armamentarium are why do we explant spinal cord stimulators? Dr. Jason Pope, Dr. Van Buyten out of Belgium have looked at that. And so a lot of the things we're doing right now are ways to mitigate that risk of explantation. All right, so jumping into the evidence, the efficacy, the E in SAFE. So before 2015, honestly, guys, there was like one randomized control trial with Dr. North comparing it to reoperation after surgery, and it wasn't, a huge cohort. It was decent, but after that, there were a lot of case series. It wasn't until 2015 we had Senza RCT, and that was, as I said, published in Anesthesiology, and then we've had 2 level 1 RCTs afterwards with DRG stimulation and with the Sunburst trial. There are many, many more coming along. In my opinion, this is the dawn of finally, we have evidence to support what we do. So it's a really important time for you guys. You're in the midst of it. You have to think about those technologies. Why am I using, HD? Why am I using HF10? Why am I using burst? Why am I doing that? It all comes down to evidence, right? Yes, there are biases in a lot of these papers, right? Industry sponsored, a lot of the authors are consultants. The challenge is, of course, these technologies are so expensive. Who's going to pay for such a study? You're not going to expect NIH to do so. You're not going to expect it to be done pro bono. So unfortunately, there's going to be some industry bias for some time, but hopefully we get to the ultimate RCT, sham-controlled with no industry bias, and that's probably for one of you to do in the future, maybe in 10 years. All right, so the vendors, every year I do this, there's like a new vendor, okay? So when I started doing this, there were 3, and now we're up to 7. Nuvectra, as you might have read in the paper, just filed for Chapter 11. Nonetheless, here are the companies. And here's just a gross overview and some of the things that you can ask them about as far as questions, or they'll try to sell you on as far as what they think is better in their product or their company than others. But really what it comes down to is MRI conditionality, how many contacts, the implantable pulse generator. The current versus voltage debate is really kind of done. That used to be a big deal when I was a fellow. And then the patterns. This is kind of hot right now, right? Which patterns, waveforms do you have available to you? And if you guys want, you can get my email address at the end or anytime, and I'm willing to send this as a PDF in case your iPhones don't work as well on the monitor. So DRG systems, there's really only one DRG system. There may be another company who thinks they're doing DRG. Don't be fooled. There is only one DRG stimulation system, okay? And that is with entry into the epidural space, creating tension relief loops, which I'll just talk about in probably 15 minutes here. All right, and the next frontier, I think you're going to hear a lot about this through this year, especially at NANS if you go, are feedback mechanisms, right? So historically, all we've been doing, as we talked about at the outset, was putting a lead in, providing electrical stimulation. But how did we know if we were giving the right dose, okay? So rather than just giving the electrical stimulation, now the new idea is, well, what's being sent back? Do we have a feedback mechanism? And the answer is, we're working on it. So evoked compound action potentials, or ECAPs, are what can be measured from the exact same leads that are being used for spinal cord stimulation. So basically, it's like a pacemaker, right? You have a pacemaker that provides the current to start the rate, but you also get sensing in that pacemaker, right? So similarly, with the spinal cord stimulator, those leads can provide the electrical stimulation, but they can also sense what's going on. And one of the things that I think they'll highlight on is that the positional aspects with tonic stimulation are mitigated with ECAP. So as that patient changes, their position, the CSF thickness changes, the ECAPs are changing in such a way where it's telling the spinal cord stimulator to lower the dose or increase the dose, so it maintains that patient in the therapeutic window, which you can see in the upper left and upper right hand graph. So the open loop is sort of our current traditional way, and the closed loop is when they turn on the feedback. so it keeps that patient in what they describe as the therapeutic window. Their therapeutic window is described as the minimum is when they first started to feel it, and the maximum is when it's uncomfortable. So that's how they define their therapeutic window, but I'll just tell you guys that may not necessarily be the therapeutic window, right? That's just their sensation window. That's not necessarily their therapeutic window. Very important point. So they're working on things. They're probably not going to commercialize for another 12 to 18 months, but very interesting concept. All right, moving on now to peripheral nerve stimulation, which is my baby. So there are now, oh boy, like 6 or 7 peripheral nerve stimulator companies. Some of them you'll get your experience with today. SPR Therapeutics is in the upper left. So what they have is a coiled lead, which you can see is very delicate, held in that hand. The coil is very cool because it's elastic. There's a tine at the very end of it, which you can see in the bottom left-hand corner, and it provides about a 1 centimeter radiation of electrical field. So you don't have to be right on the nerve. You can it's actually better for you to be a centimeter away from that nerve to create its effect. The upper right hand is StimWave. They do both spinal cord stimulation and peripheral nerve stimulation, tined and untined leads. Again, external power source. Then you have the Bioness, which is, again, external power source, tined lead, implanted adjacent to that peripheral nerve, so you actually don't want too much distance. And then on the bottom right is sort of the new kid on the block. This is the Naidu microstimulator. You can see the microstimulator itself is the size of a dime. And what patients will wear is that therapy disc, which is there in the white circle. And we have a special adhesive you use to place that disc over the IPG, and that powers the patient throughout the day. And then they have an app, so you don't need a different programmer. Naidu was able to convince the FDA to allow them to use their app on your own personal device. So this is a gross comparison of all the peripheral nerve stimulator systems. The variability in these systems is far greater than what you're going to come up with in spinal cord stimulation. Part of the reason you may not hear as much about peripheral nerve stimulation, frankly, is because, number one, reimbursement is not as great as spinal cord stimulation, but secondly, there is so much unknown. It is which nerves, which indications, what's the distance to nerve? Should we be using efferent stimulation, so actually using motor stimulation to provide the negative afferent effect, or should we be using afferent stimulation? So many things to think about, but this just gives you a brief idea. All right, so societies. One of the things you'll probably spin your head about is all the societies that are out there. Who should I join? They all cost money. You know, who's in that group? Who's in this group? This frustrated the heck out of me as a fellow. There are too many darn societies. So I think it's important, though, as a fellow especially, the dues for these are all $0 to $10 or something. You guys should join as many societies as you can right now. And sometimes they forget to ask you to pay when you become an actual attending, and then you get $10 membership for another few years. So take advantage of it. These are the societies I am involved with or have been involved with. So there are obviously more, so this isn't a totally comprehensive list, but I encourage you to get involved. You guys are truly the future. I mean, I'm here, as Dr. David said, because we care about you guys. We want you to do well. I'm going to be a patient one day. I want one of you putting in a stimulator for me and doing it the right way. So I think the best way to get educated is these societies, and furthermore, staying current with some of the newer conferences that are coming out. So the International Neuromodulation Society is actually the parent society to NANS. They have a conference every 2 years, and the next one is in Barcelona. We just got back from Sydney here in May, and it was a wonderful conference. I think the advantage to this is you're seeing how neurostimulation is being used in other parts of the world. It's really eye-opening how they use it for congestive heart failure, how they use it for tinnitus, how they use it for all sorts of functional neurological disorders. It's really amazing. This is a huge growing field. So to get a glimpse of that, I encourage you to come to NANS in January in Vegas. This is my own little plug. I am on the board of directors for CalCIP, the California Society of Interventional Pain Physicians. We just had our annual meeting 3 weeks ago in Lake Tahoe, and it was a great success. We had over 300 registrants. So it's going to be in San Diego, warmer for next year. I encourage you to come. We have a lot of great people speaking. And then the journal that I think specifically for this field you really should have available to you is Neuromodulation. This was a tiny journal when I was a fellow. It was 5 articles, like my anesthesiology, ANA, and like our APM were like this, and that came and it was tiny. Now it's growing thicker and thicker and thicker and thicker because there's so much input in this field. All right, guidelines, in case you want to know what are our guidelines for neurostimulation, for DRG, for intrathecal pumps, as Dr. Askew will get into tomorrow. These are the guidelines. So the NAC guidelines, the NAC DRG guidelines, the PAC guidelines, really follow these. This will help you understand which antibiotics, what do I do with antithrombotics, what do I do about positioning. It's all in there. And then once you get into this field, I strongly encourage you to measure your outcomes. We are no longer in an age where we can say we're awesome, I'm the best. We really need the best measures possible. I don't want to say objective because, right, we're in pain. This is pain medicine. We're not cardiology where we have blood pressure and heart rate and ejection fraction. We're pain, right? So a lot of this is subjective, but nonetheless, you've got to measure it and you've got to understand the trends. So here are a number of questionnaires, instruments at your disposal. Really, I think the PROMIS 29 is the one go-to right now because it's fairly comprehensive as far as function, severity of pain, psychological aspects, and sleep. And a lot of our studies are going to focus on the PROMIS 29, but nonetheless, you have all these other instruments to look at. And when you look at the studies, you should really hone in on these and understand what these mean and how they apply to that technology. So to summarize, I know this was fast, guys, but hopefully it gives you a taste of things to come. Neurostimulation really is an effective method to manage pain, not only from our evidence, but also from our experience. With the opioid epidemic, which is maybe not as hot as a topic as it was maybe 3 or 4 years ago, we really need to look at other therapies. This has certainly helped a lot of my patients get off opioids completely, and we can talk about that further if you have questions about that. Really, our goals are to improve function, reduce analgesic medication use, and improve quality of life. I'm really in the camp of mitigating all medications. It's not just opioids. They all have side effects. The NNHs for a lot of these drugs are smaller than the NNTs. That's a problem. And a lot of this has been influenced by drug companies. And you might say, well, you're being influenced by device companies. So it is a little bit of a battle, but just try to think about those things for your patients. And when you choose these patients for neurostimulation, you've got to be extremely scrupulous. You've got to understand, what their psychological background is, how they interpret this technology, how they're going to incorporate it. I just saw a patient who had mild cognitive impairment. That's a huge challenge. She's 79 years old. How is she going to understand this technology? Can we make it simple enough for her? And is her husband going to be a good enough caretaker to help her through that process? It is costly. These things cost thousands of dollars, and you might not care, and you might think, well, I'm getting paid, who cares? It really does affect everybody. So as I mentioned, our healthcare costs are becoming astronomical. That's why our political environment is talking about Medicare for all. We really do need to understand our costs and take ownership, because if we don't, someone else will. And the technology continues to improve. So where I was when I was in your shoes, it was bare bones. It was like 1/10 of what you see today. So imagine 10 years from now what we're going to have. It'll be pretty impressive. And education. So I really appreciate all of you guys for being here, because maybe you want to check out Seattle, but moreover, it really is an investment in yourselves. I personally think the reason our outcomes have become much better in the last 10 years is not just the technology, it's really because we're teaching people better. We see a lot of individuals, clinicians who've been out in practice for 10 or 20 years, really understanding, like, if I don't go back and learn some of this new stuff, these young guys are going to catch up and beat me. So it's really cool when I teach these courses to see, 60-year-old guys who've been in practice for 35 years. I learn a ton from them, but it's just great to see that they're open-minded enough to come back and learn these new things. And I strongly encourage that for you. Don't think that once you're done with fellowship, your education is done. It's a lifelong process. You have to actively seek these opportunities. Otherwise, before you know it, it's going to be over your head. So with that, maybe I'll open it up to 5 minutes of questions before I get into dorsal root ganglion stimulation. Yes. Yeah. So I used to, when I was at UCSF, track the WHO Disability Assessment Scale 2.0 and the Oswestry. We had EPIC, and so what that enabled me to do was, whoops, oh, it's up there. it would be automated. So patients would get an email, and they would fill it out, and then we'd have a time graph to see what their scores were over time. In my new practice, we're private practice, we're cheap, we can't afford Epic, so we have paper forms of Promise 29, which I've adopted because that's really going to become the standard, not only for reporting to payers, but also for a lot of the studies we're going to be doing in the future. So that's what I use right now. Great question. Any other questions?
Hey, Ramana.
Yes, Doug.
A couple of tips about your go-to for back, like a garden variety patient comes in with refractory degenerative disc disease and some radiculopathy. You presented a lot of systems.
Yeah.
So just kind of a breakdown of what would be your fastball, your curve, and your slider.
So it kind of depends on lots of factors. My go-to, honestly, if it's a patient who's willing to accept an implantable therapy, I personally use Burst DR. I've had great outcomes with it. It's paresthesia independent. We've gotten to a point where we're now doing anatomical placement, so the trial times are super short. What's interesting is you're asking about my curveball. We've had a lot of good success with SPR therapeutics, primarily for facetogenic pain, in which patients who might have sort of over time failed their medial branch RFAs, and you're wondering, what do you want to do? But they say, I don't want to have a spinal cord stimulator, I want that battery. We put in the 60-day lead on each side for that medial branch, taken it out, and patients have had sustained relief, which is pretty remarkable. So that's sort of my curveball. And then going a little bit deeper, there might be some minimally invasive spine stuff I'd consider in those situations, as you're going to allude to. Great question.